Welcome to episode 7 on the hand, wrist, and thumb. We are putting up a poll right now that you can take. Just some questions before to get your opinions on the subject. First of all, I want to thank everybody for the last 7 weeks. It's been really fun. I think you've really done great to be able to come into these things and share the excitement, really, even though we can't hear you talking or doing anything. We kind of feel the energy a little bit, knowing how many people are in the room. After looking at the feedback, we anticipate our next webinar will be on June 24th. That's 4 weeks from now, but it's a little based on our speaker availability now that everybody's getting back to work. We'll keep you updated and decide whether we're going to do the on-demand version of CEUs. The CEU certificates for NATA and NSCA will be emailed out in a few weeks. If you have any questions, you need to contact Nancy Patterson at nancyflynn1@gmail.com. But she'll be sending those out based on all the surveys you guys have done, and it'll be a collective number of CEUs. We also have seen some people, especially the professional levels, lose their access to their work emails temporarily. If you are one of those people, please send us your second email. We're going to send out an invitation, but it won't be an invitation. It'll be, do you want to update your contact information? It's not a real invitation, but it gives you an opportunity to give us your personal email so we can get the next invite to you if something unfortunate happens. If you give us a second email, we keep both of them, and then we'll send them both out on the next invite. Or you can contact Nancy for other information. So again, thank you very much. You've really been great in regards to the questions, but also the feedback you've given us. We've gotten quite a few emails on the pros and cons of things, and we've tried to implement all those things. We're going to kind of get right to the conference. Steve Shin from Curlin Job will be speaking. Mo Herman, who's an occupational therapist but does some unbelievable stuff with orthoses and bracing in regards to hand injuries in sports. Drew Scott from the Pittsburgh Pirates is going to give us the ins and outs of what to do on the mound when you see a blister, and how do you get them back on the field afterwards. So I'm actually really looking forward to that talk. Steve Shin, board certified hand surgeon. He got his BS, MS, and medical doctorate at Brown University.
Hey Stan,
Yep.
Are you gonna talk about your paper real quick?
Yeah, I will. Hang on. Okay, that's right. I'm sorry. I'm gonna, oh boy. Thanks, Nancy. That's why she's there. I'm gonna give about a 8 to 9 minute talk on epidemiology of hand injuries to give you some perspective on what Dr. Shin's gonna be talking about in regards to the epidemiology. As everyone knows, epidemiology is boring. A lot of numbers, a lot of charts, but I'll try to go through them, make sense of them so you can see how often at the professional level we have these. So I'll be talking on that first. To continue on with Dr. Shin, New York University Hospital for Joint Diseases in his internship, and New York University Hospital for residency in orthopedic surgery, and he went to Stanford for his fellowship. He's a director of hand surgery, and he's a member of the Curlin Job Institute of Board of Directors. He's a clinical faculty at Curlin Job and is a chairman on the Curlin Institute. He's lectured and widely authored numerous book chapters and journal publications, and he is a Case Colony top doctor, has been named by the country's top hand surgeons. He's a hand consultant for the Dodgers, Angels, and Kings, Rams, USC, and Loyola Marymount. Okay, I'm going to switch gears here and go into this epidemiology. Okay, this is a article we wrote in 2019 when we kind of discovered there wasn't much epidemiology on hand wrist injuries in Major League and minor league baseball. So we did this study. And in order to give you some overall perspective in regards to hand and wrist injuries versus other injuries in baseball, we're using a study that Christopher Camp published last year on the summative report on time out of play for Major League Baseball. It's a pretty good study looking at 50,000 different diagnoses that was put in the HIT system. And you can see here, this is a busy slide, but you can see the hamstring strains at the very top. And if you look over here at percentage, you see 6.7% of all diagnosis in Major League Baseball were hamstring strains or tears. The next one was rotator cuff at 3.8. So what we do see, though, is 7 different other diagnoses that make the top 50 that are from the wrist and fingers. So there's a significant number. When you add these up, you get 4.5%, which makes it really second in diagnosis from that particular standpoint. So these are quite a few injuries that we see. So we're going to kind of try to break them down. We used HITS data. I had to have Steve Donahue in a picture because he's the most photographed athletic trainer in baseball. So this data was from 2011 to 2016. It included the preseason, regular, and postseason. What's important to know about this is that not every HITS system, HITS data that is published doesn't take into account preseason and postseason. That's usually just regular season. We did all 3 parts of the season. Defined as at least one day of practice or play. Total number of injuries, 6,226 injuries over that time. 14% of the injuries were in the major league, and 86% were in the minor leagues. That correlates to the percentage of major league players to minor league players as well. So you typically see that mix. The mean days missed per injury was 17, but the median was much lower at 5 days. Again, another important thing to look at when you're looking at studies, they use mean days versus median. Mean days is the average, and when it shows high at 17, it means it has a lot of outliers, probably on the end of several people taking a very long time and moving the average up. The median is a halfway point between all the different dates, and a lot of times is more significant than the average. There were no upward trends. There were no upward trends. The number of injuries during this time period did not go up or go down. And this shows it here. This is wrist injuries and hand and finger injuries segregated out. You can see it's a pretty straight line across, nothing statistically significant as far as increases go. When you look at this slide, I wanted to highlight the frequency of the surgeries versus just being injured. Major League had 9.2% of all the injuries in the hand and wrist went to surgery. In the minor league, 6.7%, and the average overall for both of them together was 7.1% of those injuries actually went to surgeries. And when we compare hand to wrist injuries, we saw a significant increase in the number of days missed between hands and fingers and wrist having a higher number in regards to that. And when you look at frequency of surgeries, we see a lot more in the wrist than we did in the hands and fingers. So that's important to notice in regards to the incidents that happen. What about the common mechanisms of injuries and activities? Well, you see that the number 1 is contact with the ball. That's probably a hit by a pitch or something else. But you can see it's 43% there. And again, based on the contact with the ball, the batting is the number 1 at 40%, but 30% of them were from fielding. When we look at positions, you can see that infielders had the most number of injuries in the hand and finger and in the wrist. But I want to note this 20% catchers and 15% catchers. You've seen some of the studies, and some of the studies that we've done, we've normalized the data by position because there are 4 infielders on the field at one time and only 1 catcher. So when you start to use that denominator, when you look at catchers, you find that catchers actually lead most injury rates in just about every location. Okay, looking at these in the hand and finger from a diagnosis standpoint, hand contusion, we see that the most often. The guy doesn't miss much time, but has a contusion with no fracture. Look at blisters though. Blisters are right below that at 9%, but 42% are contusions. I also wanted to have you look at the thumb phalanx fractures and the proximal phalangeal fractures in the fingers, and look at the surgical rate. The surgical rate is very, very high, and Dr. Shin will be talking about that. So, okay. And what about surgical procedures? Hook of the hamate, number one, by quite a lot, 32.8%. UCL repair, 10% went to surgery. I thought that was low when we first looked at this diagnosis, and I think Dr. Shin can talk about the number of treated conservatively versus treated with a repair. And then a finger metacarpal open reduction internal fixation at 5.9%. And I'll leave you with these two articles. If you're interested in hands, you get more detailed information from these two articles that were published in the last couple of years by Christopher Camp. One is the getting hit by a pitch in professional baseball and what the outcomes are. And the other one is epidemiology and effective sliding injuries in Major League Baseball, which will also see a significant number of hand injuries. And here's some references. All right. So that was quick and dirty, and we'll turn this over to Dr. Shin. Dr. Shin, it's all yours.
Great, great. Can you hear me?
Yes.
Okay, great. Thank you, Stan. It's really great to be here to talk to all of you. It's a real honor to be able to talk to so many medical staff members of the Major League Baseball teams. That was a great introduction by Stan about the epidemiology, and I'm going to get into some of the more specifics about hand, wrist, thumb injuries right now. So let me just share my screen here. Let's see, and go to here. Okay, can you all see that okay?
Yes.
Okay, great. Thank you, Nancy. Okay, good. So let's get started. I only have about 20 or 25 minutes. So I'm going to talk about these things today, scaphoid fractures and the broad topic of ulnar side wrist pain. And these are just 4 causes of ulnar side wrist pain that I'll talk about. There are several more, but we don't have the time to go over everything. But these are 4 of the big ones. And then thumb ulnar collateral ligament tears, which is one of my favorite topics to speak about. So first, let's talk about scaphoid fractures. This is the most common carpal bone fracture. As we all know, there are 8 little bones in the wrist, 8 carpal bones, and the scaphoid is the most commonly fractured one. And waist fractures of the scaphoid, or right in the middle of the bone, are the most common, at 65%. Distal fractures of the scaphoid account for about 10%, and proximal pole fractures about 25%. The proximal pole ones are the ones that we are more concerned about, given the precarious blood supply to this bone that I'll get into in a second. The mechanism of injury is basically an axial load. So you can fall on an outstretched hand, but the wrist is hyperextended, is pronated, and it's ulnar deviated. If your wrist is more in a radial deviated direction, you're more likely to get a scapholunate ligament injury. But when it's ulnar deviated and in these other positions, you're going to get a scaphoid fracture. So it's all about that darn blood supply to the scaphoid that gives it this bad reputation. This is a picture of the scaphoid here, and distal is to the left and proximal is to the right. You can see number 1 at the top. That's a dorsal carpal branch to the radial artery. That supplies about 80% of the blood supply to the scaphoid. And you have about a smaller percentage coming from the more distal contribution, and then you have some contribution from the ligaments as well. But it's that dorsal carpal branch that's really the main branch supplying the blood supply to the scaphoid. So you can see proximally to the right, that's where those tiny little branches go, and you don't get much blood supply there. You might get some ligamentous contribution, but not very much, which is why proximal pole fractures are at higher risk for developing AVN or osteonecrosis. So, the question I always get is, if you have an athlete, baseball player or any athlete with a non-displaced waist fracture, do you really have to operate on them? My opinion is you should, yes, because it's a much more predictable rate of healing and return to play. So, there is literature out there that talks about treating these non-operatively with a cast, and 90% do heal if you're able to cast them. But an average actually is about 3 months. So many of you may have thought it was shorter than that, like 6 or 8 weeks, but it's actually closer to 3 months if you take into account all scaphoid fractures that are not displaced and at the waist. So my preference is to put a screw in it. Just put a screw in. It's very easy to do. You can go either anterograde or retrograde. And if they can play with an orthosis, great. If they can't, then they can't. And most baseball players cannot play with an orthosis on their wrist after surgery. So you got to kind of wait it out. I usually like to get a CT scan at about 4 weeks, sometimes 6 weeks, but I found that if you can get it at 4 weeks, you'll see some partial healing there. And if you see about 50% of healing on the CT scan, then I let them go back to play. I know that with 50% of healing and with a strong screw in place, it's extremely strong, and I have no reservations with allowing them to resume baseball activities. So back to proximal pole fractures here. You can see an X-ray right there in the middle. That's at the junction of the proximal middle thirds. So that's a proximal pole fracture. Sometimes the fragments are even smaller than that. And you can see on the right, that's what AVN looks like. You've got a lack of blood supply to that proximal pole, and you get on this sequence of MRI, you get a very dark proximal pole there. So for proximal pole fractures, I always fix them in anybody. You want to get those fragments lined up. You want to get good compression at the fracture site and really try to decrease the chances of the patient getting osteonecrosis or non-union of this injury. So the risk of AVN without treatment, by the way, is about 33% for these proximal pole or proximal 1/3 fractures. So it's kind of an easy way to remember this. If you have a proximal pole 1/3 fracture, 33%, right? 1/3, 33% chance of AVN. So yeah, sorry, there it is, and there it is on the MRI. Okay, so that's scaphoid fractures. We're gonna move quickly on now to hook of hamate fractures, which I'm sure you're all very familiar with. Extremely common injury in all stick handling sports, but especially baseball. The typical history is that the player will feel some sharp pain on the bottom hand for a right-handed batter as for a left hand. And you'll get these x-rays, right? You get x-rays of the wrist that shows the hamate bone very nicely, but sometimes you'll get the reading of a negative x-ray. Why? Because you can't see a hook of hamate fracture on your typical 3 views of the wrist, your AP oblique and your lateral views. You need to get a special view called the carpal tunnel view, which is actually not that easy to get correctly, and sometimes it's very difficult to see. So I just skip it. I just go straight to the CT scan to make sure that I'm ruling out or ruling in a hook of hamate fracture. On physical exam, you'll be tender. The player will be tender right where the hook of hamate is, and it's about 1 centimeter distal and radial to the pisiform. And you want to make sure you check for ulnar nerve paresthesias because the hook of the hamate forms the radial border of Guillen's canal. And so Guillen's canal is right next to the carpal tunnel. And within Guillen's canal, you've got the ulnar artery and you've got the ulnar nerve. And the ulnar nerve supplies sensation, as we all know, to the pinky and to the ulnar half of the ring fingers. So, when you have this fracture, you can get hematoma, you can get swelling, you can get injury to the ulnar nerve. Make sure you check the sensation. Make sure you check for motor strength as well, because ulnar nerve supplies us a lot of the intrinsic muscles in the hand. So have them abduct their fingers and see how strong they are. Make sure that's intact. Make sure you check the flexor tendons to the ring and small fingers. Those tendons pass right by the hook of hamate fracture site to the ring and small fingers, and sometimes they can be injured as well. So make sure they can flex the PIP and DIP joints of those digits. And obviously check for the ulnar artery. Sometimes you can have injury to it. You can get a pseudoaneurysm or thrombosis. And you want to make sure you don't have a bounding pulse there that might make you concerned for a pseudoaneurysm in that area. So let's go back to imaging a little bit. On the left is a carpal tunnel view. The blue arrow is kind of pointing to this fracture, but it's very, very hard to see. And this is a pretty good carpal tunnel view. So I just go for a CT scan, which I'm showing here on the right. And you can see pointed by the arrow there, the fracture. This is my typical incision for excising the hook. I just make a short longitudinal incision right over the hook. Some people will go through the carpal tunnel. Some people will go more ulnarly, more through the hypothenar area. I like to go right over it. I dissect right down to the hook of the hamate, being careful to retract the ulnar nerve and artery. Make sure that the flexor tendons in the carpal tunnel are not in the way as well. And subperiosteally elevate, remove that hook of the hamate. Make sure you're very careful of the motor branch of the ulnar nerve, which is passing right around just distal to the hook of the hamate. So if there's things, so you got to make sure that these structures are retracted and protected while you take it out. And that's the hook on the right. You can see there it's about 1.5 centimeters or so in length. And that's kind of a typical hook of hamate size. After you do this, you want to make sure you smooth out the base, get a little rongeur, make sure there are no little spicules there that might rub against the nerve or the artery or the flexor tendons. This is a study that we did a few years ago, and you can see here we looked at this return to play after hook of hamate excision in just baseball players. We had a number of professional, collegiate, high school players, and median return to play we saw was around 5 weeks, but there was a range of about 3 to 7. And compared to the HITS data during this period, it was a little bit shorter. Compared to, according to the HITS data, is about 7+ weeks, but in our experience is about 5 weeks on average. So in terms of take-home points, this is a very common injury, as you all know. I've seen a lot of patients where they come to me after trying to be treated non-operatively with a cast or a brace for several months or even longer, and they're very frustrated. They've lost so much time. Maybe they missed a season because their doctor told them, you know what, give it a chance to heal. I don't do that anymore. If I see a hook of hamate fracture, especially in a professional ball player, just go and take it out. It's very predictable to return to play pretty quickly. They can start moving very quickly back to kind of baseball activities within about 3 to 4 weeks, and then back to play, like I said, around 5 weeks or so. And partially healed hooks can also be painful. So even though they may be stable because there's partial healing, don't get fooled. They can be symptomatic as well, and the best thing to do is just to take it out. Okay, so let's move on to ulnar-sided wrist pain now. Again, I'm going to just talk about a few different causes of ulnar-sided wrist pain, and the most common cause of ulnar-sided wrist pain is a tear of the TFCC, or the triangular fibrocartilage complex. So last C in TFCC is complex. So it's a complex of different structures. It's not just one simple structure. And you can see a picture of it on the right, on the upper side, on top right here, and on the bottom right is an MRI. What I've circled there in red is that black structure that going from the radius over to the base of the ulnar styloid, or we call it the ulnar fovea, and that's where the TFCC attaches. So this is a kind of a ligament between the radius and the ulnar, very important for stabilizing the distal radial ulnar joint. And there are 2 different types here according to the Palmer classification. I'm going to focus more on the type 1 tears, the traumatic ones, versus the type 2, which are more degenerative. The traumatic ones are the ones that we usually see in our players. And there's a couple types based on location that we usually see, and it also dictates kind of treatment as well. The one structure I want to kind of point out to you here before I move on is the ligamentum subcruentum. It's a long 2 words there, but complicated 2 words. But just think ligamentum is the deep layer or deep fibers of the TFCC. Is that dark blue thing in the picture? That's the part that really attaches to the base of the fovea, to the base of the ulnar styloid, and then over to the radius. That's the most important part of the TFCC. So if that part is torn, then you have to be very, very wary of possible DREJ instability, which is an indication for surgery. So in terms of treatment, if the DREJ is stable, you could try treating them non-operatively. You can put them into a brace of some sort, or you can arrest them. You can see if they'll get better over the next 4 to 6 weeks. But if they don't get better, then you have to start thinking about other options. You can consider cortisone injection or other things. But if the DREJ is unstable, or if the pain just doesn't go away, no matter what you do, then you have to think about surgery. And if it's a central tear, like what I'm showing there on the right, that you see a little probe kind of hooking the tear there. You see a little flap of the TFC. That's a central tear, the most common type of tear of the TFCC. And these will just debride. Put in a little shaver, remove the torn central portion, and leave a nice stable rim. That's the most important part. The central part of the TFCC, the articular disc, which is torn here, is a very poor blood supply, kind of like the inner third of the meniscus. So that's why we go in there. You do a partial meniscectomy in the knee. Here we're going to do a debridement of the central articular disc, the torn disc of the TFCC. But if you have instability of the DREJ, then most likely you have a tear, a type 1B tear, which is a peripheral tear of the TFCC, torn off that fovea that I mentioned earlier. So if you have instability, you want to go in and you want to repair the TFCC back down to the fovea. Some people talk about doing a capsular repair, which I used to do, but I don't like that anymore. I've had some failures. I like doing an anatomic bony repair of the TFCC back down to the fovea. And here's just an example here of what instability looks like at the DREJ. Okay, you can see the scar there. He had a previous ECU tenosynovectomy, but he still had instability, and I found a peripheral TFCC tear there. So in terms of techniques for repair, you can do an open versus arthroscopic. Arthroscopic is very common. Open is common as well. And if you look at the literature, there's really no difference in terms of the outcomes. You can do a capsular repair, which is non-anatomic, or you can do a foveal repair, which is a bony repair and anatomic, and this is my preference. So again, no difference, but I like open and foveal. I think it's better for the following reasons. So you know you're going to get that ligamentum, that deep layer of the TFCC. You can't see that ligamentum if it's torn and the superficial part is intact. And I see that sometimes. You put a scope into the wrist, you're only going to see the superficial lamina, superficial layer, and you're not going to see that deep layer. So when you do it open, I can see both layers. I can see the torn ligamentum, and I know I'm going to get it and repair it back down. A lot of times in these patients with instability, you're going to have a loose capsule. And when you do it open, you can tighten up this capsule as well. You can put lots of little absorbable sutures into the capsule. Sometimes I even have to excise some of the capsule to get a nice tight capsule closure. And I think that really helps augment the stability that you get with the TFCC repair. And then you can also address other pathologies like ECU tendon instability. Maybe you have a snapping ECU tendon or tenosynovitis. You can do the tenosynovectomy at the same time. Maybe the patient has an ulnar styloid non-union or impingement. You can remove the styloid, or you can remove a little part of the part of the styloid if they have impingement as well. So other things you can do with an open approach. These are just some pictures now in a cadaver showing you how I repair a TFCC. I just make a straight incision over the ulnar styloid, just the ulna. I'm grabbing the TFCC with my forceps there, and I'm going to pass the suture through the peripheral rim of the TFCC. You can see right here, I'm just using a fiber wire to place this grasping horizontal mattress stitch in the peripheral TFCC. And what I'm doing now is placing these suture tails through this eyelet of this anchor right here. It's called a push lock anchor. Go ahead and drill a hole in the distal ulna, which you can see there. I'm about to put both of these suture tails into the hole, and then this is a completed repair. I just kind of mallet in the anchor here. It's a very, very strong repair. And then I go ahead and I just add some small absorbable sutures to augment the repair. I address the ECU tendon if I have to. I just close this in layers and then put them into a cast for about 4 weeks. So again, here's the post-op, sugar tonic splint for about a week, and then I give them a Munster splint or cast for the next 3 weeks. At week 5, I'll start wrist flexion extension, not supination and pronation yet. I just want to get their flexion extension going. Supination and pronation, that really stresses this TFCC, so I'll wait until about week 7 to do that. Strengthening at about week 9, and then return to play at 3 to 4 months, which is pretty typical. So anyway, my post-op protocol. Let's move on to the ECU tendon, another cause of ulnar static wrist pain. The ECU tendon travels right there dorsally and ulnarly over the wrist. The ECU subsheath itself is part of the TFCC, by the way. So remember I said the last C is complex. Part of that complex is the ECU subsheath. And the ECU tendon can be a real cause of ulnar static wrist pain, whether it's inflamed or unstable or so forth. And so if you look here, this is a really nice picture in pronation on the left. That's when the ECU tendon is a dorsal and ulnar. It travels nice and straight over the wrist to the ulnar base of the fifth metacarpal. And on the right there, you can see in supination and flexion what happens. And this is typically what football or rugby players do. You can see the wrist is flexed, it's supinated, and they're gripping something. And that's when the ECU tendon is on most strain. It kind of takes this curving course, kind of a 30-degree angular course around the ulnar head. And that's when it's at most risk for injury. In terms of pathology, what kind of pathology can we see? We can see tenosynovitis. You get an inflamed tendon. You get tendinopathy, which is more kind of a chronic thing. You can get where you kind of get this degenerative tissue, tendinosis you can see on an MRI. So more chronic thing with tendinopathy, or you can get the very common and dreaded instability of the ECU tendon. And this is a subsheath problem. There's a classification right here. You can see that in A, it's just normal. In B, you get the so-called periosteal stripping. So, it's still kind of intact, but the ECU tendon starts to subluxate out of the ulnar groove. And then in C, you can see that there's an ulnar tear of the subsheath, and it finally can kind of dislocate from the groove. And in D, it's a radial-sided tear, and then in E, a contracted sheath where the ECU tendon is just gone, but the sheath is kind of reformed beneath the tendon there. This is kind of a neat test to keep in mind for all of our trainers and out there. This is called the synergy test, described by Rulin and Hogan in the Journal of Hand Surgery in 2008. You can see that for tendonitis, this is for ECU tendonitis, not for snapping tendon or unstable tendon, for tendonitis. You basically have the patient bend their elbow, have the back of their hand facing you, and then with the fingers and thumb abducted, try to squeeze with the thumb and middle finger. Okay, and when they do that, they're going to feel the strain. You're going to feel the ECU5. You're going to feel a strain in the ECU tendon, and that could be a sign of ECU tendonitis. Obviously, for snapping, you can see that with forearm wrist rotation. You can see an obviously snapping tendon in and out of the groove. Ultrasound is a great imaging technique for looking at the ECU tendon. You can see here in these images, the ECU in a sagittal plane on top, you see the ECU tendon, and the black stuff is fluid surrounding the tendon, and on the bottom there's a tendon, and again a lot of fluid surrounding it. This is a sign of tenosynovitis. Here's an MRI axial cuts of an MRI of a wrist. And you can see on the left here where the ECU tendon is located right within the groove. It's a nice deep groove. Some people have a shallower groove though, like you see right here, and they're more apt to dislocate their ECU tendon. And you can see that right there, dislocating ulnarly. In terms of treatment, on the left for tendonitis, I basically will recommend immobilization, just rest them for a few weeks in a position of extension and ulnar deviation, okay? That's the most kind of relaxed position for the tendon. And obviously load management, isometric exercises you can do. You could try a cortisone shot. I wouldn't do more than one, at most two, because there's a risk of weakening the tendon and rupture. So I try to limit those. And also, you can do a surgical decompression if you absolutely have to. If they don't get better, just cut the sheath of the subsheath of the ECU tendon, like when you do a decurvatus release on the radial side, and the tendon usually stays stable. If you have an unstable ECU tendon, you immobilize for 6 weeks to about even up to 4 months sometimes in a position of pronation and radial deviation. That's the most stable position for the tendon. And if that doesn't work, you can recommend surgery, repair the subsheath. I like to use a few little anchors, just repair the subsheath, but not too tightly. You don't want to strangulate the tendon and restrict blood supply. You immobilize them for about a month, and then return to play is generally about 3 to 4 months. Good. So let's move on to ulnar styloid fractures, yet another cause of ulnar styloid wrist pain. And so, especially in baseball, it's very common, right? Hit by pitch, direct impact, maybe with a ball especially on the bottom hand. And you can see a picture here of the ulnar styloid on the bottom, and you can see how the TFCC attaches right to the styloid. And if you have a base fracture of the ulnar styloid, the TFCC can get disrupted. And then you lost your connection between your radius and your ulna, your important connection, and you can get DRJ instability. On the right is a fracture of the ulnar styloid. These are very, very commonly associated with distal radius fractures. As you can imagine, again, that connection, the TFCC is a connection between the distal radius and the base of the ulnar styloid. So you can see how some pull of the TFCC can cause a fracture of the ulnar styloid. Now, this is a classification for non-unions, but I like to use this for just ulnar styloid fractures in general. I think it's very useful. Type 1, you have a tip non-union or fracture, and you can see here the TFCC is not attached to the tip. So these are pretty benign. They may be painful for several weeks, but they are pretty benign. Sometimes they can cause some impingement on the triquetrum bone, as you can see. And in type 2, these are base fractures. These are the ones you really have to watch out for, because the TFCC is now attached to the styloid itself. And if you have a base fracture, you can have DRUJ instability. In terms of a workup, the player will present to you with complaints of pain, limited motion because of the pain, maybe a weak grip. On an exam, they'll be tender right over the ulnar styloid. You might have some swelling, and they might have pain with certain maneuvers like ulnar deviation or supination. You want to make sure you test the DRUJ with a shuck test, basically move the radius and distal radius and ulna kind of back and forth and see if they're unstable compared to the other side. You want to get x-rays to see the fracture. And if you have difficulty doing that, you can get a CT. And I oftentimes will get an MRI because I want to see more than just a fracture. I want to see the TFCC and see how that is as well as maybe the lunar triquetral ligament or other associated injuries. Again, this is a Munster splint here. I like these for ulnar styloid wrist pain because it prevents forearm rotation, especially supination, ulnar deviation, the maneuvers that can, the movements that can cause ulnar styloid wrist pain. Here is what do you do though if they need surgery. So the indications for that, if they have an unstable distal radial ulnar joint, like I mentioned before, after you fix the distal radius fracture, then you got to do something. You got to go in there, you fix the ulnar styloid. There's different ways to do it. You can use pins, as I show here, as a tension band construct on the top. Some surgeons will use plates. I don't normally do that, but you can do that as well. Or if they fail non-operative treatment, then yeah, you should go in and do something. So in terms of options, if they have pain only but no instability of the DRUJ, you can repair the styloid with pins. You can use a screw, or you can just excise the styloid itself, because and you don't have to worry about the TFCC because they're stable. Or if they're unstable, then you can repair the styloid. By repairing that, you're going to be knowing the TFCC is going to heal as well. Or you can excise the styloid and then repair the TFCC, which I've done many times as well, and this also works pretty good. All right, here's an example of a player, professional baseball player, who was hit by a pitch. You can barely see on the CT scan, cuts right there. This the fracture pointed by the red arrows. You're like, that's nothing, right? That's a little chip fracture. They'll be fine. They'll come back in a couple of weeks. But these can be concerning because it'll keep the player out for a long time. So typically, I'll think about 6 to 8 weeks. This player was out for about 7 weeks, and you can see here on a coronal cut of the MRI, the ulnar styloid fracture and all the bony edema there associated in that area. So don't think these are just nothing injuries. They can take a long time to get back. Here's another player hit by a pitch. You can see a more base fracture to the ulnar styloid. And so this I fixed with a little headless compression screw, a really small one. It was perfect for the styloid. I also supplemented with a TFCC repair because, as you can see, this is a base fracture. He was out for about 10 weeks, but came back to play pretty well. Ignore that big round cyst-like structure in the lunate. That's unrelated. That's basically the intraosseous ganglion. Great. Okay, I know I'm taking some time, but we're going to move on to thumb UCL tear as my last topic. This is my favorite topic to talk about. I see a lot of these injuries, and as we all know, UCL injuries are a lot more common than radial collateral ligament injuries, 9 to 1. The acute injury is called the skier's thumb. The more chronic one is called the gamekeeper's thumb. I'm not going to get into the etiology of these terms, but just if you remember that, you'll be good. And typical indications for surgery, basically, if you have a complete tear with instability compared to the opposite side, you should fix the ligament. If you have an avulsion fracture that's displaced, then you know that the distal end of the UCL is also displaced. You should fix the fracture or excise it and fix the ligament. So those are typical indications. But how about, but how about return to play? I think that's also an indication to fix these as well. It's a much more predictable way to get the player back within a shorter period of time. And here's a traditional surgery. This works very, very well. And you basically use a suture anchor in the phalanx. You repair the distal ligament. You cast them for about 4 to 6 weeks, and then you start therapy. Return to play is generally about 6 to 8 weeks. If they can go back with a splint for protection, I feel a little bit worried if they go back without protection, like a splint at the MP joint, and sometimes it's longer depending on their symptoms. And without a splint, I feel very comfortable at about 10 to 12 weeks to let them do that. So this is something that we came up with several years ago. This is called a thumb UCL repair with internal brace augmentation. This was being done for lateral ankle instability with great success. And so I was thinking, well, why not? Can we do it for the thumb? It's not typically a weight-bearing joint like lower extremity joints. So I think this would have a good chance of working. Can we use this to kind of get them moving sooner and obviate the cast? And this worked really well for me. So you see a picture of it here. It basically requires 2 anchors, one in the phalanx and one in the metacarpal. The suture tape itself is a white thing going over the ligament. That's the internal brace. I use a suture to perform a traditional repair just as usual with a 3/0 fiber wire. This works pretty well. So here's a picture here. This is not a ball player, but this is the kind of a nice picture that I had of one of my older patients with a thumb UCL tear. You can see how much instability there is there. She had a chronic UCL tear. You can see how much deviation there is radially, no firm endpoint, and very unstable. So finally was able to fix her recently. You can see on the MRI there that UCL is more on the right side of this coronal cut of the thumb. You can't see it very well there, but you can see the radial collateral ligament very well in black on the other side. So intraoperatively, this is kind of what it looked like. Not the healthiest ligament. Again, this is about 6 months old. But I just put a lot of absorbable sutures in there to try to really tighten up the soft tissues on that side. I used a fiber wire to repair the ligament. And this is kind of what it looked like before I placed the internal brace. I placed an anchor called a nano swivel lock into the proximal base of the phalanx that allows me to anchor the suture and the suture tape. And also it's removable as well. I can thread it out if I need to. If I don't like the position or whatever, I can take it out and redo it if I have to. So I like this anchor. So this is a picture again of me bringing the suture tape tails proximally over this ligament into the metacarpal, now securing it with another anchor, a larger swivel lock anchor. And I make sure to do this in about 30 degrees of flexion. If you don't, you will lose thumb flexion. And make sure it's neutral in coronal plane so that you're not over tightening this as well. So it's nice to have an assistant to hold the thumb in the right position while you're securing the internal brace. And make sure you check it. You know, if you don't like it, you can always redo it. But here's a video of how firm, from a firm endpoint you get right away. You make sure they have good flexion. Okay, firm endpoint. Okay, and yeah. So anyway, that's just something I like to do at the end of videos that I'm happy with. I'm not showing you my bad ones. So anyway, here's you want to make sure you check it. If you don't like it, if you think it's too tight or whatever, you can go ahead and remove the swivel lock, and you can go ahead and redo it if you have to. So that's what I like about these anchors. Post-operatively, this is kind of what it looks like on the x-rays. That's a little nano swivel lock in the phalanx. You can see the metal body right there. Company could not make this out of a radiolucent implant. It was for risk of stripping, but I kind of like seeing the implant on the x-ray anyway, so that in the future, if you think the anchor is loose for whatever reason, you can always remove it and revise it. But these anchors are very strong. I splint them for about 10 days, and immediately I'll get the IP joint, the top joint, moving right away to get the FPL and EPL tendons gliding. I'll put them into a thumb brace at the first post-op around 10 days, and then allow gentle flexion extension. Here's a video of a Major League Baseball player just at 1 week. All right, so I like doing this at just the first post-op. They get the stitches out, they get moving, and this really helps. They don't have to be in a cast. They can get moving right away, and it really helps for return to play and prevent the muscle atrophy. So this player was able to return to play, I believe, around 5 weeks and did very well. Post-operatively, in comparison in terms of the protocols, on the left, repair without internal brace, splint them for about a week, cast them for a few more weeks, get them moving at that point. Strengthening about 6 and return to play, in my experience, about 8 to 12 weeks with or without a splint. And on the right, with the internal brace, get them moving very, very quickly. I've had some notable athletes get moving within 2 to 3 days, and that's worked out very, very well. I'm very confident with the internal brace to allow them to do that. Strengthening in a couple of weeks if they can tolerate it. And then after 4 weeks, I'm very happy with if I'm happy with how they're doing, and usually I am, they can just not wear a splint, except for a playing splint if necessary, and they return to play when comfortable. So for me, it's really changed the game for my patients with UCL injuries. In terms of some biomechanics research, we found that the time zero is stronger than just a suture repair alone, giving me the confidence to get them moving faster. And then we've looked at the kinematics as well, Ty Lee's lab here in Southern California, and found that the varus valgus kinematics were very similar to the traditional repair and intact UCL. So that was very encouraging. We did a study looking at some high-level athletes. I want you to focus on this row here. This is return to play in season after surgery. I had about 13 athletes, and they were returned to play at any level at about 31 days and at about a little over 5 weeks at the same level pre-injury. So this was just accepted for publication, and hopefully it'll come out soon. So if you're thinking, well, what about RCL tears? These are actually even more difficult for me in my hands than UCL tears. They tend to stretch out more because of the adductor pull. But these repairs with the internal brace have worked better for me than just my traditional repairs. I still immobilize them for a few weeks to get them going before I get them going. So I think this is a great adjunct to the traditional repair for RCLs too. So in terms of final thoughts on the thumb UCL internal brace, I think there are many advantages to it. I've been very happy with it. I haven't had to revise one yet. I'm sure I will someday. Nothing is perfect, but I've been very happy with it so far, and very rarely do tendon graft reconstructions anymore. If there's any kind of collagen there, I'll just kind of try to tighten up as much as I can with absorbable sutures and anti-internal brace, just like in that case I showed you. So I've been very happy with my experiences here. Okay, I think I've talked for very long enough, so I'll hand it back over to you, Stan and Nancy.
Thank you. That was unbelievable. That's great. Really like the information on the internal brace. Mo Herman, I met many years ago when we had a UCL thumb that needed her expertise, and she sure showed me a lot of stuff how she uses splints to get people back to sports. Next slide. She's a graduate of USC occupational therapy program. She has authored several chapters and journal articles on a variety of rehab topics. She is faculty at Cal State University, Dominguez Hills, guest lecturer at USC. Currently serving as the president of the American Society of Hand Therapists. And she is a former Olympic swimmer. Actually, when you look at some of her highlights, and I can't remember the year, Mo, you're gonna have to do it, but she set the Canadian butterfly 200-meter record that had been held for nine years. And she was in the '88 Summer Olympics. She is an elite athlete, upper extremity rehab. She's under 20 years of clinical experience, and really as over the last maybe 10 or 15 years has really changed her practice into working a lot or primarily with professional athletes in the MLB, NHL, NBA, NFL, LPGA, and UFC.
Okay, so thank you for that intro and for having me here today. And it was interesting to see the stats that you showed and some of the stats that Dr. Shin showed. As a rehab specialist, I'm always about trying to lower those stats and get the athletes back to play as soon as possible. So by career definition, I am a hand therapist, but for the past decade, my clinical expertise, as you've learned, has been centered around the high-level athletes. And I'd like today to just share my insight in rehabilitating this population. I have no financial relationships to disclose, and I am sharing for educational purposes. So my hope today is to provide insight on just what is hand therapy, the use of orthoses, which it is splints. In our world, we refer to them as orthoses in sports, and then give some general outline on rehab protocols for the thumb UCL, which is also one of my favorite to treat, and mallet fingers, both post-operatively and non-operatively, and then offer some rehab tips and tricks for those of you who do perform rehab with athletes. So hand therapists are occupational therapists or physical therapists that have pursued advanced credentialing to be the recognized experts in rehab in the upper extremity. The ultimate credential is the Certified Hand Therapist, or CHT. And what this is it requires us 3 additional years post our degrees, 4,000 hours, and a very difficult exam to get that credential. And then the recognized organization is the American Society of Hand Therapists. And the reason I put this up here is if you're looking for an upper extremity specialist to help you with any of your injured athletes, their websites have searchable databases by city or zip code. And the therapists are not necessarily trained in sports rehab, but they're absolutely skilled experts in the upper extremity. So there are all types of athletes that sustain injuries regardless of sport that grace my clinic. And the spectrum really ranges from professional athlete to hobbyist. And the inherent challenge in rehabbing them, especially at the high level, is the stress that's felt by all the key players to get them back to their sport as fast as possible. And this pressure is magnified knowing that the athletes are wired to be limitless, and this doesn't change because they're injured. The athletes really are a different breed, in my opinion. And it starts young. So this is a story I like to share of a 11-year-old travel high-level hockey player who had a freak injury during playoffs. As you can see, had definitely a nail bed injury, but it's unknown what he had inside. So the best we could do was splint him and then get him over to Dr. Shin, who took an x-ray and was kind enough to take the boy over to the screen and share the image and explain to him, you know, you have obviously a traumatic nail bed injury, or you have an open wound, you're at a high risk for infection. You can see the multiple fragments here on the x-ray. If you move your tendons at all and try to bend your finger, you're going to displace those fragments and you'll ultimately need surgery. So at this point, the best we can do is rest you and put you in a splint. And he turned to the boy and said, do you have any questions? And the boy said, can I play hockey tonight? So obviously what we say and what they hear is different, and it reminds me of that dog cartoon. So the ultimate responsibility kind of falls back on us who are trying to rehab and get these players back to their sports, is how do we get them back safely and adhere to the tissue healing timelines? And that really requires some innovation. So let's look at a common injury. So the thumb UCL, this is the non-surgical, like Dr. Shin talked about, that ulnar collateral ligament that's injured, where they are unstable, they have pain and swelling, especially with pinch and grip. They will often end up in a regular doctor's office, not even necessarily in a hand surgeon's office, and I will see the gamut of either a massive forearm cast to bulky prefab splints, and hopefully they get sent over to us for a custom orthosis and education. And what they really need is a custom molded orthosis, so that's where we come in. So we have a variety of materials that we utilize to fabricate these orthoses. They're thermoplastics that come in a variety of colors and thicknesses. We throw it in hot water and custom mold it to the patient's hand, and then as it cools, it hardens. We also have a variety of casting materials that enable us to make anything for immobilizing the healing tissue, from the fingers, the hand, the wrist, the forearm, you name it. Custom orthosis fabrication is a very strong skill of ours. So the best way to immobilize that joint in question is to fabricate a well-fitted, molded, custom short opponent's orthosis. And what it does is it really supports the MP joint. It leaves the IP free and leaves the wrist free, leaves the fingers free, and allows that structure to heal. And then per conservative protocols, they're usually in that for about 4 weeks, really making sure we're not stressing that healing ligament. And then they're reevaluated, and at some point between that 4 to 6 week mark, if they're not painful anymore, then we can start some gentle motion. Patient education is really critical because the tendency is to want to take it off and get going, and we really have to let that healing ligament heal. And that means, you know, not taking it off and doing rice buckets and putty and weights and stuff like that. They really need to rest. You know, at 6 weeks, if they're asymptomatic, we will start the unrestricted motion, but continue with the orthosis for protection. And then somewhere around the 8 week mark, they discharge the orthosis as long as they're not tender, and the patient education is critical, especially for up to 12 weeks of no lateral stress and avoiding tight pinch and tight grip that will stress that UCL. And for those that have a heavy use of the hand, it could be 3-4 months of immobilization. And that often is where the athletes lay, because they are not gentle with their hands. They really, really use them in their sports. So how does that go over with an athlete? It really doesn't go over very well, as we all know. So that's where I come in again, and I'm going to give you a specific example where I had a NBA basketball player. This dates me. We're talking over 10 years ago, who sustained a UCL injury, had surgery, was sent to rehab. We made the standard orthosis for him, and he was whizzing through the rehab protocol. And we got to a position where he really needed to be doing more, and we couldn't, because the literature and the protocols and the doctor said, no, you have to stay in your splint until you reach the healing timeline. So I went out on a limb and asked the doctor if I could make an orthosis that would satisfy the protection of the healing structure, but allow us to get a ball in his hand, would he be comfortable? And there was silence on the phone. And all I heard him say was, don't ruin my surgery. So I took that as a yes, and we went into prototype mode, went through all sorts of versions of trying to accomplish that goal of protecting the repair and allowing freedom of motion. And we ultimately settled on this design that allows good lateral protection of the healing UCL. You can see the bias of the material drops a lot further down on the radial side, but what it does is it also frees the tip of the thumb, it frees the wrist, but most importantly, it frees the palm of the hand for feel. And then we wrap it up and we double check the lateral stability to make sure that structure is soundly safe in the orthosis. And one of the early recipients of this adaptation was this ball player, and that allowed him to return to his sport way sooner than the tissue would have alone, would have alone allowed. So that you can see that picture here. He is back to work, and he has the thumb wrapped with the orthosis underneath. Most importantly, though, before you go crazy with making these, you absolutely have to have clearance from the physician to attempt this. And your job, or the therapist's job that'll be doing it, absolutely has to make sure that the injury is protected. Otherwise, it just doesn't make sense to progress. But what it has done for me is it has really opened up my abilities as a rehab specialist, and the custom orthosis is one of my most powerful tools in my toolbox that can be used in any phase of rehab, whether it's protecting the surgery, problem solving their sport. Remember, like, these athletes live and breathe their sport, and they're itching to get back. So giving them the ability to get their sport back in their hands, it's like a security blanket. They're going to be way more confident at discharge because we started in the clinic first, and it just opens up all sorts of possibilities. I view it as my secret weapon, really. And I'll show you several examples of the magnitude of the protective splinting in the different sports. And before I even show that, what the difference for me that this has opened up is many athletes, we go through our standard rehab protocols and we get them to a point like we would with any lay person, and then we send them off to their sports teams, and they're then have to rehab and get ready to be sport ready and competition ready, which is very different than in clinic rehab ready. So what this has afforded me is to allow to start that way sooner, so that by the time they're discharged from rehab, they're ready to return to play. That's kind of been my mission in working with the athletes. So here's an example with a volleyball player who had a CMC thumb dislocation. It's a simpler design, but we were able to build orthosis training into treatment. And it may take a few sessions to make sure the fit is just right with their sport, but they're absolutely thrilled because they think that they can't do their sport for X number of weeks, and now we get them engaged in their sport elements, and it just changes their perspective and energy and their motivation. They're just happier coming to rehab. Here's a football player with a thumb UCL repair. This athlete was instrumental in assisting with the design to ensure maximum feel while I'm ensuring maximum protection. And getting the sport back in their hands is just, like I said, a huge confidence boost for them. Here's an example of an ulnar styloid fracture in a baseball player. I made a design that bridged the prominent styloid and then inserted it in a custom sleeve. And then it's important to make sure that the hand and the sports equipment are not impeded, that it actually works with their equipment, and that their feel is as close to normal as possible. Because it's really important for me that their mind is not thinking about their hand. So that's part of the practice process, is really, really engaging it with it in their element as often as possible, so that they're not worried about their hand at all. One thing I do recommend, that if you're going to send an athlete to get a custom orthosis made, make sure you send them with their personal sports equipment to trial the customization. And oftentimes it may be a one-time referral, and they just need to know that, with the expectation that sometimes it takes more than one session for the perfect fit. We make it work in the clinic, we practice all we want, but until they get back out into their environment, sometimes there's still some micro adjustments that we need to make. Here's a basketball player with a metacarpal shaft fracture. He needed a dorsal protection orthosis to return to contact practice and competition, so just to protect him from being hit on the back of the hand. So again, we use the ball for the custom fit, and he rolls it around in the different positions that he would hold his hand. And then, so that actually wasn't so hard. What became difficult in this case was the tailoring on the wrapping to give the optimal feel for the patient or the athlete. So, in many cases, we used to go from, I'm so happy to get my ball back in my hands, to now I don't like how it feels. So many basketball players have no problem with as long as their tips are free and they can feel. But in this case, he just hated having the tape in his palm. So we had to be innovative and reduce the tape without compromising the protection. So we whittled away, and then that wasn't enough. So we came up with some other solutions where we secured it with cover roll stretch tape. We found that wasn't enough, and then we learned that we could use like the base spray Tough Skin to adhere the cover roll, and that was a nice way to get the palmar area completely exposed. So we finally got that guy happy. I had another one who that scenario on the top of the screen didn't work for him. So what we did with him is we used a more of a boxer's wrap, and we secured the orthosis initially with pre-wrap, then the boxer's wrap on top, and then we tore away all the pre-wrap and then whittled away as much of the material as possible to have the palmar exposure that the athlete wanted and the security of the protection that I needed. But the point here really is it's the same diagnosis, same orthosis, same sport, but various ways to secure, because no two athletes are the same. So I'm constantly innovating depending on what's coming to me. And then this water polo player taught me the importance of empowering the athlete to self-wrap the orthosis. So as much as I'm doing all this with them, now it's very important for me that I teach them how to self-wrap. It gives them more independence and more confidence, and the tool of advocacy to teach others how to do it for them, or that they can do it themselves if there's no one else around. And typically, I'm not worried, because usually they will overwrap out of fear, but they understand that they absolutely have to protect the structure that this was splinted in the first place. In terms of what we use in the clinic when we're messing around with the orthosis and trialing it with their sports equipment, I usually use some derivative of Coban. I like Dynarex. It works, it's fine. But for return to play, I have better success with the PowerFlex stretch tape, which is pretty common in most athletic rooms, training rooms. It's just a little bit thicker, a little bit stronger, and just a little more tackier. It just really gets the job done from a confidence standpoint. And then my last one here is a cyclist with a TFCC repair. She was sent for a Munster orthosis. Like Dr. Shin said, it locks their forearm and wrist in neutral, but that makes it kind of impossible to get on a bike. So what we problem solved was a second orthosis to allow her to get on a trainer and start practicing, and allow her to practice without breaking any of the healing tissue rules. So we came up with a design that still locks around the elbow, but then when it came to the handlebars, I had to whittle it away so that she could actually hold the handlebar. And then I had to extend the material dorsally, distally, so that I could secure it onto her hand and have the leverage I needed to ensure that her forearm and wrist were maintained in neutral, so that the doctor wouldn't be mad at me. But it allowed her to get back on the bike and start training, and it got her back to racing. And she really didn't miss a beat by being out with an injury that should have technically knocked her out for 8 to 12 weeks. So these orthoses just really open up rehab for me and the possibilities while their tissue is healing. And I know how important it is to get those athletes going and bridge that gap of finishing rehab and being game ready. So one of the safest ways for me to advance them, both range of motion and strength-wise, is to use a variety of balls. So this is one of my rehab tips that I share now when I speak. They're easier to hold early on. Different sizes, different weights for all sorts of options that allow for grading. So I have moved away from weights and dumbbells. Oops, what happened there? I've moved away from dumbbells and weights and bands, and balls are really my go-to for my athletes. It gets me away from the table. We get the whole upper extremity chain involved, and I'm able to do that because of the custom orthoses. Again, most important though, make sure you have clearance from the doctor and that you're absolutely protecting that structure that's healing. So the use of splints in sports is huge for me, and I really feel like I can make anything to get them back to their sport faster. That's kind of my mission. So I'm going to move over to thumb UCL. So Dr. Shin already talked about it and provided some general timelines for rehab. I'm offering kind of the more traditional, ultra-conservative protocols that we have. where, like he mentioned, you're looking at 4 to 6 weeks before motion can begin, and 6 to 8 weeks for strength. Realistically, they're not getting back to the high level of sports until 10 to 12 weeks, and we all know that that's not ideal for an athlete. And for me, the use of the protective orthoses and getting them away from the table certainly speeds up the timeline. Alternatively, and in contrast, the internal brace has just been a phenomenal advance, not just surgically, but on the rehab side and getting the athletes back. The timelines are extremely progressive compared to the conservative ones. And truthfully, even therapists in my industry get very nervous when I present this material because it's so foreign that we could start someone with motion in the first 7 to 10 days and strength by 2 to 3 weeks. They just can't wrap their heads around it. But it is a game changer. We can return them safely in 6 to 8 weeks. And like Dr. Shin mentioned, now currently with our high level athletes, I think we're pretty routinely getting them back at 5 confidently and successfully. So regardless of procedure, again, those are guidelines because every athlete, surgeon, injury, fixation differs. And prior to every single rehab admission, I discuss the timeline with the surgeon, and that's how I get my confidence as a provider. So I will come at the surgeon, and I'm talking Dr. Shin here, with my list of when can I questions. And I want to know all of this before I start. When can I start upper body strength? When can I, fabricate the sport orthosis? And I go down my list. The two that, obviously are the most important for the athlete is to know, when can I go back to throwing? When can I get back to the team? When can I go back to competition? That's what they want to know. And I want to be armed with the answers. So what I do after I speak to the surgeon, I sit with the patient as part of their first visit, and I map out the timelines with them, and I calendar it with my timelines of rehab, their practice, their game schedule. We lay out short-term goals so they can see what we're working on, and we can reach that destination of return to competition and discharge together. I think it really helps to do that with the athletes. Some of the other tips with thumb UCL repair, education is monumental in terms of teaching the patient and anyone that's working with the patient that the lateral stress cannot be occurring in order for the tissue to heal and just to heal. So this is not so common anymore, but some of those patients that have been immobilized for way too long. Like, I still get some patients from some doctors who have a thumb UCL repair that casted them for 6 or 8 weeks. It's ridiculously long, and they come and we have a lot of extra work to do. So if you come across a person or an athlete who's been restricted for a long time, it's common that the web space becomes contracted, and that's a problem for trying to open up your hand to hold the sports equipment. So if that's the case, we emphasize soft tissue to the adductor rather than pulling on the thumb. Active motion is always preferable when it comes to that. Sometimes we have to make a web space orthosis, and then it just needs to be made in a way that we're not putting any stress on the healing UCL. Prioritizing thumb extension is actually quite important. I know they're going to get their flexion back, but we have to really kind of make sure that the extension is there. And then don't be afraid to get them moving. So, under the surgeon's direction, once they're cleared for motion, move them. It's okay to abduct and flex and oppose and extend in that first week, or whenever they're cleared, it's okay. And then progress them through functional range of motion activities in those same motion patterns, and add fine motor coordination. And then as you go through those, when can I question timelines, you can get them away from the table, start working on upper body stuff, and get them ready for sport specific stuff so that you can get them back to competition as soon as possible. So mallet finger in my remaining minutes, as you know, these are the terminal extensor tendon is interrupted, where there's some forceful hyperflexion of the distal phalanx. They'll either have a soft tissue separation or an avulsed bone that comes with it, and that's kind of your clinical presentation. And that droop there is what we refer to as the extensor lag. So many will show up in our clinics with some version of this, and then some version of this shows up. These are just simply way too much. It's overkill. You really just need to immobilize the distal IP, ideally in hyperextension, and leave the other joints free. As far as custom goes, this is the traditional one that we make with just a basic DIP hyperextended with the rest of the joints are open and free. The biggest problem is maceration on the volar digit, where they just have worn it for so long that they start to sweat and the tissue just becomes pruny, like you've been in a bath for too long, and that can result in skin breakdown. So my preference is to make this combo design where it actually leaves the volar part of the digit primarily exposed, and it seals on the dorsal side. There's some literature that says that the casting materials, the casting tapes, have just better compliance and less skin issues, but the outcome is the same in terms of the wear schedule. So if someone, this is just protocols now, if someone has an acute injury that we consider it's less than 3 weeks, they're splinted in DIP hyperextension for 6 weeks. It's okay to move the MP and PIP, so the joints around it. They do need to take it off to let the skin breathe, but they absolutely have to hold that DIP and extension. You can't take it off and let it droop. So you have to transition from orthosis to holding it. And if it inadvertently flexes or they go and make a nice fist, then the splint wear schedule starts over. At 6 weeks is when we typically will start to increase active motion at the tip and then continue with the orthosis between exercises and at night. But I am constantly watching the extension and measuring that, and that's dictating my how I'm titrating, whether I'm weaning slowly or how quickly and how fast the orthosis will come off or not. Generally speaking, by 8 weeks, they're just wearing it at night and adding some strength, and by 10 plus weeks, it's off altogether. They're further categorized if it's a chronic injury and it's greater than 3 weeks, and the biggest difference is at the time 2 weeks. So it's the same everything. It's just now we're just 2 weeks longer for everything. My basic tips for this is to absolutely prioritize extension. I know they'll get their flexion back, but you have to go slow, because if you lose the extension, it's very difficult to recapture. It's not uncommon to have a 5 or 10 degree loss from neutral, and that's kind of clinically acceptable. Obviously, we don't want that, but anything more than that, it's a failure. Never do you want to be pushing passively on the tip, ever. Volar-based orthoses are preferable to get that DIP hyperextension, and then to prevent slippage, you could add some DISOM or add some powder or alternate a volar and a dorsal version to prevent that skin irritation. The other one is just the education for the patient. You have to really stress that they can't take it off and that they have to maintain the extension or it will start over, and that they can't bend. And the biggest one is they can't just stop wearing it cold turkey. Sometimes they go back and the doc says they don't need it anymore, but it really, really has to be weaned. It can't just be stopped. And then for those that never heal but don't really want surgery or non-surgical candidates, these oval 8s are a nice over-the-counter kind of option to hold it straight and allow them to function with just basic daily tasks. And then lastly, for surgical repair, that will require the doc to put in pins or wires or screws or some way to secure the bone fragment or tighten up the stretched tendon if the conservative treatment failed. And at this point, they're put in a tip protector for continual wear. Again, just the tip, the MP and PIP are left open. And then at the discretion of the surgeon, somewhere around the 6-week mark, they are transitioned, and that's when motion begins. And again, extensions prioritized. This is the only time that gentle passive motion may be initiated, but it will really depend on the leg and how the finger is doing with active first. If they're not moving well, we can consider some dynamic taping or splinting to get the motion. That does require physician clearance. And my tips for this, no matter what, I know we have those general outlines, but every patient's different, and every surgeon's different, and every tissue is different. So before I start, I go back to the surgeon for my when can I questions, and I get my outline on when I can start active and passive and splinting and strength. So I have a good idea of what I'm doing when I'm working with my athlete or my patient. Again, prioritizing extension. And sometimes with these, the reason that they can't bend is because of scar tissue. So just doing a lot of soft tissue work can regain the flexion. education, education, education. And can these engage in sports? Absolutely. But again, you need the MD clearance and be sure that the tissue is protected. I will make it with any of these 2 splints that I already talked about, and then we just securely wrap it with the tighter tape. Usually a 1 inch is enough for the digit, and I will go further down. I won't just stop. I'll have the security down the length of the finger if I need it. So in summary, the various use of custom orthoses has been huge in athletes for me. I hope you're able to leave this segment of the talk with some additional tips for any of these that you see yourself, especially with the thumb and the mallet finger. So some references there and my contact information, and thank you.
Great, Bo. I just want to make a little bit of a plug for Mo. You know, I met her obviously with that Dodger player, and what I learned from her mostly was that there's another professional out there who is really qualified to help us in regards to all this. And she doesn't just customize an orthosis, she customized the customized orthosis and works a lot with the ATC and the PTs to be able to get this to work. That particular player that she worked with was a reconstruction, and I wanted to get him back in 6 weeks. Dr. Shin threw something at me and said no. And we did end up getting an orthosis, and he did come back in 6 weeks. But it was due to the fact that this was on his throwing hand, and the orthosis had to be customized so he could rotate his thumb underneath, and that little bit of rotation to get your thumb underneath the ball and also be able to hit. So we had to customize that several different times to get it right. And so this is another really significant tool in your tool chest in regards to hand injuries and looking for a certified OT who has sports experience. And you should write down her contact. She is a great information person to be able to help you with your particular hand injuries. Okay, so we'll move into our last talk. And this is Drew Scott. He's going to talk on the management of blisters and nail care of pitchers. He earned his BS from Manchester University in northern Manchester, Indiana, and he's a AAA athletic trainer in Indianapolis for 3 years, but he was in the minor leagues for quite a long time. And that's the reason I really wanted him to talk, because as all you minor league athletic trainers know, it's just you, and you've got to figure out some way to make it happen, and especially with the blisters and the nail care that you see on pitchers. He's currently 12th year with the Pittsburgh Pirates organization, recently promoted to the athletic training coordinator for the Pittsburgh Pirates, and he is the owner of Scott Athletic Training in Fort Wayne, Indiana. Drew.
All right. Thank you, Stan. All right. Should be good to go here. We're going to switch gears a little bit, and we're going to cover the blister and nail care for baseball players, and more so specifically for the pitchers. So the blisters, as we all know, it's a result of repetitive friction and strain between the skin and various objects. Typically, that's seen when the friction comes against the seams of the ball. As the image over here on the right shows, you can really see where the blister forms underneath that layer of skin there. And that's due to the forces transmitted through the thumb, the index finger, and the middle finger when pitching. But typically, the highest form of force comes through that middle finger, where that middle finger meets that nail plate. And a lot of this depends on the type of pitcher throwing and the type of pitches they throw. And oftentimes after trauma or irritation, hydrostatic pressure causes the accumulation of the serum, which is basically a clear fluid that builds up within 1 to 2 hours, and sometimes even quicker than that. And as this image shows, even though these blisters are small in size, they have a significant impact on performance. They They really mess with the fine control of the pitches that the pitcher is trying to throw. If they have a lot of pitches in their arsenal and they can't really put a lot of pressure on that on the seams or on the ball, it's going to affect their performance and it may alter their mechanics. So how blisters form? The first two here, the amount of pressure force applied and the number of repetitions, they have an inverse relationship. So as the force goes up, it takes fewer reps for the blisters to actually come about. And then the last two here are really out of anybody's control, is the moisture of the individual, which we've seen that very dry and very wet skin produces low frictional force, but moist skin or just very damp skin produces the highest friction, which can cause more blisters. And then humidity. I know in Indianapolis it gets pretty humid and you can't control that. And the amount of sweat that these guys have really messes with the moisture on their finger, on the ball. So oftentimes you can see blisters pop up just because of the humidity in the air. How to handle this? It really just depends on the individual. Prior to games, I've seen guys take antiperspirant spray deodorant, put it on their forearm and on their hand maybe 20 minutes before the game. And that really helps limit the amount of sweat that's going to be rolling down the forearm onto the hand. Obviously, they don't coat that too much because that can mess with the friction on the skin as well. And some guys will put their hand in rice buckets in between innings. If it's the starter, they'll have that right by them on the bench, or they'll have that down in the swing area in the cage, and that just helps prevent that pruning of the skin. But inevitably, some guys are just prone to blisters, and that could be due to the moisture on their skin. And various ways to treat these after the formation is you can clean the area with an alcohol prep pad and drain it with a sterile needle. You got to be careful when doing that, though. You only want to penetrate that top layer of the skin, and it's a fine art when and where to do it. You want to find, if you are going to drain that blister, you're going to find the spot of the hand that touches the ball the least. You go and stick you stick the blister in an area that is coming in contact with the ball quite a bit. That can also mess with mechanics. It can alter how they grip the ball. So you got to be careful when you decide to pop that blister. And then you can do those in games. Like I said before, you want to make sure that you're doing this under clean conditions. You don't want to just do this in the dugout, where there's dirt around and just not a safe area. I would be very cautious if you're going to do this in game for reasons that I mentioned before. You stick that needle in the wrong place and you irritate the skin underneath there more. You're more than likely having that pitcher come out. And so if you do decide to drain that in game, you're going to want to monitor that skin just to make sure that doesn't open up anymore and become a balls and create a highly irritated area of skin that lies underneath that padding of the finger. And then some guys use skin adhesives, Dermabond or Crazy Glue, and they'll usually do this before the game. For multiple reasons, they don't reapply in game. And one thing that I've seen that guys have tried to do this on their own, where they've applied Crazy Glue in game, it does a nice job of covering the blister or that callus area near the nail bed on the finger. But what I've seen is that it often dries it out and it cracks and it makes things even worse, especially if this happens, if it's a starter and it happens in the first inning, they cake on super glue. And next thing you know, by the third inning, you got this nasty looking blister, kind of like this guy right here. Obviously, this was more on the padding as opposed to near the nail bed. So once they are removed from the game, you'll want to just assess the area, see if it needs to be drained again. Oftentimes I've found that when you're dealing with blood blisters near the nail bed, those things can fill up pretty quickly, and they can do that multiple times if you continue to drain that and they continue to throw. And then, like I mentioned before, a tricky thing that you want to be cautious of is if that thing does open up and involves skin, and you open up a new area or sensitivity of skin underneath that, you just need to be cognizant of the pitch of the pitcher and what type of pitches they throw, and the amount of sensitivity that they have in that area. Some guys can handle a little bit more pain than others. So I would just be cautious on getting them out of the game and automatically cutting that skin off, because if it's a reliever, you don't know when they're going to be up again, especially in the higher levels of pro ball. You don't know if they're going to go back to back. You don't know if they're going to go 3 days in a row, or you don't know if they're going to not pitch for 5 days. So there's multiple things there that you have to take into account before you just go and cut the skin off. One thing that I've found that works great, and a lot of people do this, is soaking it in betadine solution. It has a nice cleaning effect to it. You just put that finger in a nice warm water, let it soak there for about 5 to 10 minutes, let that area get clean. And then I always have the guys go shower just to kind of clean off even more, and then come back. And then I like to put a nice coverage of zinc oxide and put a bandage over that. And I'll send them home, if it's a day game. I'll tell them to keep it on for a couple hours just to try to avoid that pruning of the skin. But if it's a night game, I'll send them home, tell them to keep it on there for an hour, let that zinc really soak into the skin, and then take the bandage off for the night and let some oxygen get to that area. Because I found that, just obviously the covering of the area lets that zinc kick in, but uncovering the area, letting the oxygenated air get in there does just as much good of drying that area out. Last thing here is the what I like to call the rodeo rub mixture. It's a mixture of the benzoin tincture and alum, which is a cooking spice basically. So you mix them in a cup, stir it up, and it gets this nice little tacky substance that you put on the area over a callus, over a non-open blister, and it really forms a nice hardened area there, which allows guys to they can do that a couple times, file it down, get a nice feel for it, and it does a nice job of toughening up that skin and callus area. A couple things to be aware of too is with blisters is infections or unforeseen issues. As I mentioned, the benzoin, this particular case right here, this player was allergic to benzoin. So we did not know that at first. We put the rodeo rub on there. We sent him home the next day. I think it was actually that night he sent me a picture and said, "Hey, is this normal?" And that part of his finger had swollen up and just had a nice allergic reaction to the benzoin. And so we had to come up with alternate ways of trying to make that heal and toughen up that skin without doing anything that was going to make it more angry than it already was. I think this picture here was about 3 or 4 days after we found out that he was allergic to the benzoin. So obviously we had to change up our protocol there. We continued with the betadine soaks and the zinc oxide to really toughen up that skin. And we decided to continue throwing with him. Obviously, he was a starter. We did not feel he was comfortable enough to go every 5 days, but we wanted to keep the arm going. So we found ways to cover that area so he could throw to continue the arm motion instead of shutting him down completely and having 2 issues to come back from, and that's the finger and the shoulder from a buildup standpoint. So we decided to cover and just continue to throw, whether it was something like 45 feet, 60 feet, the arm was still going, but we were continuing to basically do a small overload and pressure on that finger to kind of harden up that skin that was starting to form underneath where the blister was. And then shutting down or moving them to the IL, that's an individual case depending on the player, how often they get blisters. Are they used to this? How ugly is it? Does it turn out like this where it affects most of that padding on the finger? Does it rip open a lot of skin? There's just a lot of variables in there, and each case is going to be individual to that player. A couple things that I've seen work for guys is just nail care on their own. A lot of guys will go out and get fake nails or go get manicures and go get those things professionally done. The fake nails on there, those guys have usually dealt with blisters before in their career. They're pretty savvy on knowing their nail length. They know how to take care of that. They're constantly filing it down. But they just feel like in order for them to continue to go and to be able to pitch every 5 days or be called upon in the bullpen, getting a fake nail on there is really what they need. And then just keeping the area filed down, especially for calluses there. A lot of times blood blisters can form underneath the callus, right where that nail meets the finger. And that, again, is typically seen where, the type of pitch that they throw and the amount of pressure that they're having on the ball with the type of pitches that they throw. These pictures right here, the one on the left, was after we found out the player was allergic. We cut back the skin and we started over the process again. I think this was a day after we found out he was allergic, to where we were able to get in there and really assess what we were dealing with from a blister standpoint. And then a couple of days later, here, this picture on the right, it really healed up. And he was able to go. He wasn't shut down very long, or he didn't miss too many games from that standpoint. And then the second thing here is nail fractures. These are pretty common. They're typically seen in the middle finger as well. They can happen vertically or horizontally. More often than not, they're happening horizontally, so they go across the nail. And again, this is repetitive stress and pressure with the ball coming off the tip of that finger. This picture right here is actually, again, one of our players. And this was, I want to say, about a week old. So these things can happen. They don't have to happen in the game, or they don't have to happen in a bullpen session where, it's the third day and he's pitching in another 2. This one happened during the COVID-19 shutdown, where he was throwing bullpens every Tuesday and Friday. And I mean, he was a normal pin. He said it was about 30 pitches, and this happened. So these are pretty common. This player has he typically gets these about 1 time a year, and he knows how to handle this. So as you can see with this picture, he decided to trim that nail down. He cleaned the area. But obviously, if we're on the field, we're gonna assess that. If that happens in the game, make sure they're not bleeding all over the ball. You want to see how it affects them mechanically. Is it affecting their pitches? Is it affecting their grip? And if you deem that they are able to stay in the game, you'll want, in between innings, bring them in, clean the area. If it is possible, clip that portion of the nail off, or clip it down as much as possible, and just let them go to pain tolerance. So it's really just this again is just an individual case, and this player, for instance, has had multiple issues with this. So he knew exactly what to do in this situation. So like I mentioned before, this doesn't have to happen just in games. This can happen in throwing programs. This can happen in bullpens, and you'll want to make sure that the area is cleaned, nice and clean. And then you can find different ways to cover it. So what we have done in the past, and these images are taken from the PBAT's website for nail fractures, is if you have steri strips, have the player put their hands down, and you'll want to create multiple layers with the steri strip. So the first one's going horizontally across, second layer is coming vertically, and then you're cutting off the access to make sure that nothing is leaking over the nail and may affect the path of the ball or how they grip the ball. And then you'll want to just put a little layer of super glue over the top of that. That just adds the longevity of the steri strip. Now, a couple things that I've switched up on is I've found that some players don't like the steri strip for whatever reason. They don't like how it feels on their fingernail. They don't think that it feels natural. And some over the past year or 2, I've moved towards just cutting off the adhesive portion of the bandage of a regular Band-Aid, and then kind of clipping it down to size, making sure it follows the contour of their fingernail, and then putting a layer of super glue over the top of that and letting them go at it. And that usually stays for about 5 to 7 days. But typically, once you get in there, you find out that no blister or fingernail fracture is really the same. And you just got to come up with creative ways of keeping these guys on the field, keeping their arms going. And if it's deemed significant enough, you'll want to actually shut them down to let that heal, because you don't want to create further problems and just trying to have them throw through this and then all of a sudden alter mechanics with shoulder or elbow. So you really got to be aware of what you're doing, not just with the fingernail, with the blister, but you got, as the whole shoulder elbow goes, you know, these things, this is the last portion that touches the ball, but it's a really big portion of the throwing process. You want to just be aware of the player, the type of pitches they throw, and then what you're doing for that fingernail. So that's it. I know it was short and wanted to keep it that way, but looking forward to the questions you guys have.
Great, excellent. We'll bring back the panel here so for some question and answers. We've got some good questions from the group. So we'll wait till Mo gets back on. All right. Just a couple things real quick. Dr. Shin, differentiating TFCC versus ECU tendonitis. Do you ever use selective injection to distinguish between the two?
Yeah, I definitely have. I think it's very, very useful, but you have to be very careful with the injection and make sure you're not, getting it into two places at once as well. So, obviously for a TFCC, you want to do an intra-articular injection and kind of bathe that area and see if the pain goes away or not. For the ECU, you want to make sure you stay extra-articular and go inside the sheath, and ultrasound can be very helpful for that. So selective injections, yes, can be very helpful.
Nancy, how about a question from the group?
All right, another one for Dr. Shin. Would you recommend conservative treatment and then surgical intervention with a TFCC injury?
Yeah, if there's no DRJ instability, I definitely would try conservative treatment first. I think that, some of these can get better. I've seen some people get better with conservative treatment, but, the tough question is sometimes it has to do with timing for these professional athletes and how much time do you have. And so, pretty predictably though, that with a central TFCC tear, you can go there, debride it, takes 20 minutes, and then get them moving in about 7 to 10 days. And then return to play. My experience has been on average about 6 to 8 weeks. But some players take longer, some shorter. But yeah, I would try, if there's no DRG instability, I would try conservative treatment for non-operative treatment first, and see if that works. I would probably just rest them for 3 or 4 weeks, and then see how they feel. Surprisingly, some players do get better without surgery.
Kind of going back to the TFCC, I was actually a little surprised on how kind of up you're on the TFCC. Originally, almost everything on the ulnar side was a TFCC tear that required an arthroscopic repair or debridement. On your MRIs that you look on ulnar side wrist pain in a hitter that he has it with the swing, do you see asymptomatic MRI changes in the TFCC, or is it generally the cause?
Yeah, so the ulnar side of the wrist is really, really complicated, as you all know. So I will see changes within the TFCCs. A lot of times they're degenerative changes. They may be, so you might just see some signal within the TFCC without a frank tear. On an MRI sequence, or you might have a partial thickness tear of the TFCC, and sometimes I'll even see full-sided, full thickness, like pinhole tears of TFCC, and the player is asymptomatic. So you really gotta, you can't just treat the MRI. I know a lot of times surgeons like to do that, but we want to treat the player. And so, again, lots of things you have to look at, not just the TFCC. You have to think, okay, well, maybe that onset wrist pain, is the ECU okay? Is the triquetrum okay? Is the LT ligament okay? Are the volar ulnocarpal ligaments okay? Is the hook of the hamate okay? All these different things. Do they have pisiform hypermobility? All these different things can cause onset wrist pain. So, but a short answer to your question is yes, you can have changes on an MRI, and have the player be asymptomatic.
Nancy?
Oh, do you have any methods to prevent dependence on the orthosis once they are healed?
That's a good question. I personally haven't had that experience. It's usually the other way. The athletes want to get rid of the orthoses sooner than we want them to. The other part of that too is that a lot of times by the time they are released from me, they may still be wearing the orthosis, and then I don't know if there's dependence because they're not in my care anymore, if that makes sense. The few times that we've had the need for an athlete, not that we've had the need, but the athlete has opted to wear the orthosis longer than we even recommended, we weren't necessarily upset because we felt like it was still another layer or mechanism of protection for the injury while they went back to play. And I think it ultimately just becomes an athlete, like it's a security blanket for them initially. You know, the final orthosis that they're wearing when they go back to play is as minimalist as possible, so it doesn't impact the use of the hand. So it's usually an add-on that's not a negative, if that makes sense. So I don't know if it's someone who's had a specific experience where it's impeded their ability to play, but in our cases it hasn't. And if the athlete still wants to wear it and they feel better with it and safer because that's how we've rehearsed, it kind of has become a non-issue. And the longest they've worn it is for the remainder of the season, and then the next season it's done. So it just hasn't been an issue in my presence.
Drew, in your experience, you have these players, these pitchers specifically, that no matter what you do, they have a blister problem throughout the year. One major league guy comes to mind almost automatically, where they miss a month, 2 months, and have a problem with that. What's your strategy on that guy, like you talked about before, who always has a problem? Is there some preventative things that you can do to try to get ahead of this, or do you watch them closely, or how do you do that?
You know, it really just depends. I know the player you're referencing, but from my point of view, the guys that I've had that have had repetitive blisters, they've been more of the blood blisters that fall right by that nail bed or the nail plate. And I like to just put that, you know, apply that rodeo rub on there as much as possible and have them file that down and kind of do that process for about, 10 minutes, do it a couple times on there just to see if we can harden up that skin as much as possible. There was one player that I had, I think in 2017, he had dealt with it quite a bit. And he had some spray, I forget the name of it. It looked gimmicky, but he swore up and down by it. So I think it more so just took away the moisture from his skin than anything. But it really just depends. I've had a lot of success with that rodeo rub, just putting that on there, filing it down, repeating that process.
Yeah, well, in the area that you talk about always was the hardest for me, and it's really where the cuticle pushes up against the nail and you start to have a problem right there. Do you ever trim back the cuticle before that happens, or is it worth it?
Yeah, we'll suggest that at times. What coincidentally enough, most of the people that have blisters are apt to just chewing their fingernails. The one guy that I pictured, he was a nail biter and he constantly bit his nails. So he didn't use any fake nail or anything like that. He was always just biting his fingernails, and he ends up with blisters. So it was one of those things to where, yeah, try to trim back that cuticle, but also don't bite your fingernails.
Nancy?
All right, let's do another one for Drew. If you do have bleeding during the game for blisters, what's your best method of controlling this and allowing them to return in a timely manner?
Well, if this is a starter and they open up in the first inning, you really got to be careful of how long you want to let them go out there, because you can make things worse. If this is April, May, and there's not a lot on the line right then and there, you can get them out and really get ahead of the process of cleaning that area. But if it's later on in the game and they're able to kind of hide that blood from the umpire by wiping it on their pants or whatever, getting them in between innings and really just cleaning that down with hydrogen peroxide, alcohol prep pads, whatever the pain tolerance is, to the player. Some guys say, hey, just dump alcohol on it and I'll deal with it. But I've even tried putting a little piece of that adhesive portion of the bandage on there to cover that and really just get by as long as possible.
Yeah, the umpire, they don't like blood on the balls. That's usually a time that they actually will look at some fingers in there. Um,
Yeah.
I guess it also gets to the thing of when you go out to the mound and you have a problem, and the umpire standing right behind you, there's not a whole lot you can do, but in the dugout, you can do a few things. You probably won't say it, but I'll say it because I sure as heck did it. I'd use just about anything I could to stop the bleeding, put anything on it, try to cover it up, and let them go out there, even though we all know the league rules is you can't put anything on a pitcher's finger.
Yeah, we all have our secrets. So
yeah, I'm sorry. Yeah, Nancy.
All right. Why is the relaxed position for ECU tendon pathology different between tendonitis and instability? One is extension ulnar deviation, and the other is pronation radial deviation.
Okay, so the relaxed position for tendonitis would be, supination and ulnar deviation, because that's the more relaxed position. I might have misspoke earlier, but it's the stable position for the ECU tendon is the pronation and radial deviation. That's the stable for. So if you have an unstable, a snapping ECU tendon, you want to immobilize them in pronation and radial deviation. That's going to keep it stable. So I guess the differentiation should be the stable position of that, the radial of pronation and radial deviation versus the most relaxed position for ECU tendonitis, which is the opposite.
While you're on that subject, instability of the ECU and the sheath, what's the operation you do for there, and what's the success of that operation?
Yeah, it's been, I know traditionally people talk about using a piece of the extensor retinaculum, and making a little flap out of it and pulling it underneath the ECU tendon and then suturing it back onto itself. That's not an anatomic repair. I never really liked that, although, it did have some good success rates in the literature. I always liked an anatomic repair where I put 3 tiny little anchors into the ulna. And then I just repair the subsheath down, not too tight. So again, you don't want to strangulate the tendon. And that's worked really well. So in my hands, I've had very good success with it. I still mobilize them for about a month afterwards, and then get them moving. There's probably some scar tissue that forms that helps me, that helps my repair. But that's what I do now.
Have there been any studies? It's like Dr. Elatrage says, in my hands, it's always 100%. I don't know about the other guys. Have there been some studies out there of success on that surgery? Because it seems like a really delicate surgery.
Yeah, the literature, no one really publishes their bad results. So what I know about the literature is that the results are pretty good for these different treatments, whether it's the retinaculum, whether it's an anchor repair, what have you. From what I know of the literature, the results are pretty good. I'll just say one more thing. Thank God there's Drew Scott to take care of everybody with blisters, because I certainly don't want to. It's a really tough topic, and I'm glad he's out there.
It's not pretty, but somebody's got to do it.
Hey, can I ask a question for you, Drew? Also,
Yep.
Do you do any work on the preventative side, like working on building calluses to decrease the risk of blistering? Is there any efforts in that regard?
Not really. We try to let the repetition of throwing allow that to build up that callus. We haven't really done a whole lot with that, of trying to try to manufacture a callus in that area. So it's an interesting topic and I mean, something to look into. But from what I've done, I've never really tried that. I've always allowed throwing and getting the feel for the ball to build up that callus.
It's interesting too. The callus on the hamate area for hitters is a real problem because they build such a big callus, and the preventative measure is to shave that callus down and not get it too big. So if you tear it, you tear the whole callus off, which is a disaster. So early spring training, early season, where they're hitting more and more and more, they develop that callus on the hamate, and that needs to be shaved down all the time. Nancy, some more?
Yes, speaking of that, for everyone on the panel, have you seen any recommendations that have been effective in reducing the hook of hamate fractures in hitters?
This is probably a person who has stock in axe, the axe bat.
Expat, yeah.
Yeah.
Yep.
So just from my standpoint, when people really had a problem with that, or even were coming back, we would shave down the handle, the knob, and then this other company has designed one that supposedly would reduce the hamates, because the concept is that the knob hits the hook on a swing and fractures it. I don't know.
So Stan, so I would have a question on that. I think we talked about this before when you're in LA, but you know, do you really believe that it's the knob in the hand that causes a fracture, or?
Oh, I actually don't. It just doesn't make any sense to me. And why would happen with some people and not other people? There's a couple different things, and when you actually go back and look at the literature in the 1920s, in assembly lines, you would see hook of the hamate fractures, not with trauma, but with repetitive use. And then there were some people who wrote some articles. They were a little iffy articles, but that the flexor digiti minimi wraps around, I think I got the right tendon, it wraps around the base of the hook of the hamate. And we were looking into this at one time to think that this was actually a stress reaction that occurred from that. And our theory was that the closing of the glove and the swinging caused this. And that we started to look at the fact that we kept seeing a history of prevalence of hook of hamate fractures and surgeries in catchers. And of course, the catcher squeezes all the time. And whether that was a stress reaction that occurred first and then the fracture. We couldn't find a statistical significance on catchers compared to other position players.
Mm-hmm.
So you know, it's interesting. There's no question it happens. I also thought it was interesting in our epidemiological study with the HITS data, only about 73% of the hook of the hamate fractures were operated on. And I can tell you, when I was with the Giants and with the Dodgers, it was 100% operation, because you would never let that thing heal. I mean, we used to talk about, you should know it's a hamate fracture by the time the player walks back from the batter's box. Mm. Yeah, it's a hamate fracture till proven otherwise. And surgery was, I mean, 75% on any surgery, any injury is a high number, but I think that's low for, you know, I'm sure the people had their reasons why they didn't do it. But, so,
right.
All right, another one for Mo. For some of the chronic conditions that require significant soft tissue work, have you used ART or anything similar? And if so, did you feel like that helped?
Good question. I'm a big believer of soft tissue work. Additionally, I'm a believer of doing it manually with my own hands. I'm not a fan of tools, so there's a lot of tool use out there, but for me personally, I lose the feel. Like, I rely on feel just as much as an athlete relies on feel. And when I have a tool in my hand, I just lose that perspective, and I just can't tell. So everything I do is through manual use. So sort of answering that question, not specific with that technique, but just manually.
Mo, a lot of people are asking to get your info, and they can get it by looking at the video that we'll put online and be able to get all your information. But how do the people in different cities find a person like you? I know you're unique, but you're becoming less unique, I hope. How do they find, they can't just find an OT who works with hands. As you said, it needs to be a certified hand therapist, but how can they go about to find someone who is doing this on the sports medicine level?
That's still very challenging. I'm still kind of unique, as you pointed out. I'm kind of the groundbreaking person and trying to teach my industry of what we are capable of. I view it as an extension of what we already do. You can start with the databases. Anybody is absolutely welcome to reach out to me specifically, and I can try to see if I know someone that is in that geographical area. Otherwise, I'm happy to help as well. I've kind of positioned myself in a place now where I'm doing a lot of remote care or before the pandemic hit, I was flying and traveling to the athletes, or the athletes were coming to me. So it's a variety of choices. We're still developing. I'm hoping that there'll be more and more therapists that are confident in working with athletes, because there are athletic therapists. It's a shift for us. It's a paradigm shift. We were never trained to work this way, and I'm hoping to kind of change that for the future of our industry.
Nancy?
Yep. A bunch of questions for Drew on ratio of benzoid to alum, or how exactly you use the rodeo cream. If you can just maybe elaborate on that a little bit.
I always just make a lot of it. I pour a little bit of benzoin in a cup, and then kind of eyeball the alum, because it's not really just for one player. You find out, you set it out, that a lot of guys will come up and put it on randomly. So I always just make enough, and you kind of want to have a nice like grimy substance. You don't want it to be too liquidy, which is too much benzoin, and you don't want it to be looking like powder, which would be the too much alum. You want to have about a 50-50 split of that. And I always just set it out. I mean, guys will just find their way to it and randomly put it on, and they'll find out that they like the way that it feels, and I'll just continue to use it. And then oftentimes after about 3 or 4 days, that'll dry out. And I always have spray alcohol bottles. I'll just do 2 pumps of alcohol in there, and it loosens it up and breaks it back up, so it lasts a little bit longer. So yeah, that's really my secret to mixing it is eyeball, kind of how I cook.
Yeah, I think it's great. When you listen to any athletic trainer who's done this, you just get a little grimy. And everybody knows what grimy is, or gristly, or this kind of stuff, and it's all kind of eyeball, and it all works. I think we should probably give credit to Stan Johnston. I don't know if he still sells the rodeo cream. He was the Cowboy Dodger head trainer that really developed that and marketed it. So we should probably give him the credit for where he is right now. Nancy, any more?
Yes, a few more. What's the estimated percentage of how many physicians are using the internal brace at this time with surgery?
That's a good question. In my office right now is 100%. But nationally, I'm not really sure. Actually, I get a lot of surgeons do come up to me at meetings and stuff, and they talk about their experiences. But I don't have any idea how many are doing it. I think that it's certainly kind of made a name for itself with athletes. But I'm not sure. I know a good number of surgeons, but I really don't know what the percentage is.
When is there a time, like when you talk about the internal brace that Jeff Dugas does on the UCL, he evaluates the integrity of the ligament to decide whether he can do a repair with internal brace, or even just a repair versus a reconstruction. That one example you had, that ligament was not looking really, really great, but you still were able to repair it. Do you ever do a reconstruction of any kind anymore?
Really, I can't remember the last time. I think it's been a few years actually since I've had to do a tendon reconstruction for this ligament. Again, if there's any kind of soft tissue there that I can, any kind of ligament, even if it's a degenerated one that kind of spans the joint, I will just to repair it and do and add the internal brace and then kind of let them fly. I think that the torque on an elbow, the stress on the UCL at the elbow is a lot different from what is on the thumb, at least when you compare pitchers to maybe other players. So maybe that's why it's a little bit in my hands. It's been more successful, and maybe that's why Jeff really looks at the integrity of the ligament. But I mean, if there's really no sign of a ligament left, then I will go to a tendon reconstruction. I always check to see if they have a palmaris before I do the surgery. But yeah, it's been a long time.
Interesting. Nancy, a couple more and we'll call it.
All right. For Drew, what did you cover the blister with while that pitcher is throwing? Did he complain about not feeling the ball? And would you consider light therapy to aid in blister healing?
for that particular player, we knew he was a starter, so we already determined that he wasn't going to start the next 5 days. But as I mentioned, we wanted to keep that arm going. We covered it with a small piece of tape, a power flex, to kind of keep the area, I guess, tight against the skin and avoid any more rubbing. Did he complain? Yeah, a little bit. But he he knew what he had to do to get through throwing, and he was more just kind of wanting to get ahead of this. And yeah, we covered it with tape, but we had already made the decision that he was not going to start his next outing. So it was already predetermined for us that, yeah, we can kind of do some heavier stuff here to kind of get him throwing. And what was the second part of the question?
Oh, about have you used light therapy for blisters?
I've never used it. I would imagine that you would have some pretty good results with that.
Do you ever use the pitching coach when you're throwing with something on there like a Band-Aid or any other things that you're using in between, or even when a guy's coming back from a blister? Do you use a pitching coach, or do you use any analytics like Rapsodo or TrackMan to look at their mechanics so they don't end up with changing their mechanics because of the blister?
Yeah, we always run all that stuff by the pitching coaches, and we're working side by side with them, and we're out there for all throwing programs to make sure that from their eyes they're not seeing any changes or alterations mechanically. And if we notice something, we're kind of speaking up and making sure that the ultimate health of this player is what's most important. And that's not just the blister or the finger, that's the shoulder and the elbow that they're dealing with, because you do not want any altered mechanics just to try to get through pitching with a blister and then have bigger problems come on down the road. As far as Rapsodo goes, we have not really. That was more of a thing that we just started looking into last year. Not so much with blisters, but with different guys coming back from different injuries. Spin rate, all that good stuff, all those fancy terms that the buzzwords that are going around right now. But we have not specifically looked at them for blisters, but we have used it for other injuries.
Nancy, how about one more?
All right. This is for Stan or Dr. Shin. Is there any data on fracture rates broken down in professionals by level from the hit system, as it seems to be that it's much more common in the younger or lower level hitters, possibly due to a much higher volume of total swings per day, as well as younger or less experienced hitters chasing pitches out of the strike zone with more awkward swings compared to upper level or MLB hitters. Thoughts being that the mechanism is chronic, leading to acute on chronic.
Well, as far as the hits data goes, we do get ages in groups. I don't know that we've gone that far down. If you look at that article, we do have it broken down by major league and minor league, but there's 32-year-old minor league players too. So we haven't looked at that too much. The hits data is really pretty good, but it's sometimes you can't dig any deeper than what's there. I got an email just the other day on the hamstring one saying, is there some data about guys on the road versus home? The idea that when you travel, then you are more likely to get a hamstring injury in that thing, and that would fall in the same category as this one. The depth of the hits data is pretty good, but it doesn't really go that deep. You probably could maybe do it, but it'd be pretty difficult to get consistent data.
Yeah, what he said.
Yeah. Okay. Thanks. All right. Good. Listen, well, we're going to wrap this thing up. I can't thank you guys enough for showing up and listening, and with the great questions and everything else. This will definitely be on video. You've got a poll that's just popped up to rate all these people and us and give us any ideas. We are planning in a month to do start another episode on some different things. We would appreciate any opinions and things that you would like to see as we're coming into this stuff. We are going to try to bring in a couple other sports as well. One of the episodes that we're thinking about is the concussion instead of doing the typical concussion, doing one where it's a concussion from a baseball perspective, from an NFL perspective, and from a hockey perspective. So we can get some people in on different sports that may have answers to our questions, even though they're working with different sports. So that's what we're thinking about in regards to that. And again, we will send an invite out to everybody in the next week or so if they want to add into their personal emails. Again, we've gotten several calls from people who had to change their emails recently because they were furloughed. So that's a problem in of itself, but we want to keep in contact, especially if the minor leagues aren't going to do much. So you guys have some more things to do. And we will have a decision on evidence-based CEUs and on demand. We're going to work on that during this month that we're off to try to see if we can facilitate that. Thank you, and good night.